Welcome. If you're joining us now, I'm Reda Sadki from the Geneva Learning Foundation, and we're very happy to be in just a few minutes. Let me check the counter. In 3 minutes and 30 seconds or so, we'll be going live with new members, new cast members in the mini-series on Serosurveys. So Simon and Kyla will be our guests. Simon Mutembo and Kyla Hayford, two distinguished researchers from the international, or affiliated with the International Vaccine Access Center at the Johns Hopkins School of Public Health. So really a team that we've had over successive episodes who are some of the leading researchers on this topic of and practitioners of serosurveys. For those of you who'd like to know more, we'll be sharing lots of resources. We know it's a quick event, but that's the point. We know how busy everyone is, and we hope you'll get enough from this so that if you do want to go further, you know where to go. So that's and we are looking at your comments and questions. We may not be able to get to all the comments and all the questions with Charlotte and Boo. We'll be doing a Q&A first with the IVAC team, and then we'll be looking at your comments and questions. But I already want to acknowledge Ruth Alote connecting from Accra, Ghana, Amel El Tahir connecting from Pakistan, and Ruth says, I'm very excited to be here. So are we, Ruth, and thank you for joining us. See you in just over 2 minutes. Less than a minute, we're getting started. Warm welcome to you from Geneva, Switzerland. I'm Reda Sadki from the Geneva Learning Foundation, and here today with William Moss, Bill Moss from the International Vaccine Access Center at the Johns Hopkins School of Public Health, together with his esteemed colleagues Kyla Hayford and Simon Mutembo. Welcome to all three of you. And of course, with Charlotte Mbu from the Geneva Learning Foundation. How are you doing, Charlotte?
I'm doing great, Reda, and I'm excited. We are already on the third day of our 4-day journey into the world of Serosurveys.
Wonderful. So I first want to acknowledge some of the people online who have joined us. First of all, our very own Dr. Tanushree Mandal from West Bengal, India, says this mini-series gets better and better with the passage of the days. This is only episode 3 of 4, but thank you, Tanushree, for that for that comment. So we've got people on Facebook and YouTube, as well as LinkedIn. Wherever you are most welcome. This is an activity we're carrying out under the umbrella of the COVID-19 Peer Hub, and I recognize many members of the Peer Hub. We are live streaming across LinkedIn, YouTube, Twitter, and Facebook. So wherever it is you're joining us from, please feel welcome. And we are looking at your comments. I see many greetings, and I'm going to go through some of them in a second. I also want to highlight that wherever you found us, you'll also be able to find yesterday's COVID-19 vaccine introduction workshop. It happened yesterday, but you can watch it, and it is very timely. It is about how you, as immunization staff, are likely to be involved in the introduction of COVID-19 vaccines in 2021. Gavi, the Vaccine Alliance, has announced that 2 billion doses vaccines will be available by the end of 2021. This morning, we had the pleasure of working with Professor Heidi Larson from the London School of Hygiene and Tropical Medicine and the Vaccine Confidence Project. She listened to case studies of members of the Peer Hub and gave feedback as well. So we are here now for this 4-part mini-series, and today is part 3. So we're going to introduce our guests. First of all, just a word from Bill to remind us, what is the International Vaccine Access Center, and what is the specific sort of expertise that you have around serosurveys?
Yes, thanks, Rita, and welcome to all of you. We're from the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. We celebrated our 10th anniversary last year, and we really helped to synthesize and build evidence to inform policy and improve access to vaccines around the world. And our team, who you've been hearing from in this mini-series, has expertise in conducting serosurveys. But IVAC is a multidisciplinary team really working on the problem of accelerating global access to life-saving vaccines through building the evidence. And we have economists, we have experts in health communication, we have epidemiologists, infectious disease specialists, a real multidisciplinary team to address this problem. And so I hope you're enjoying this mini-series on serosurveys, and you'll hear from my expert colleagues today.
Thank you, Bill, for this intro. And now, Charlotte, over to you. I'd like to ask you to introduce our guests. And I'm hesitating whether to start with Kyla or Simon. I'll let you choose.
All right, thank you, Reda. I'm actually going to start with Kyla. So please, could you just introduce yourself? Tell us where you work, what you do, and the first time you heard the word serosurvey.
I'm Kyla Hayford. I'm an associate faculty member at Johns Hopkins School of Public Health at IVAC. And the first time I heard the word serosurvey was when I was a young PhD student looking into whether you could use saliva to determine, as a marker of serology, to determine who's protected against measles.
All right. And then what about you, Simon?
Yeah, I'm Simon Mutembo. I'm a medical professional, a medical doctor working as an epidemiologist at the International Vaccine Access Center. The first time I heard about the word serology was during my medical training in Zambia, but I first got involved in the serology work in 2016, working with Kyla, Bill, and Andrea to carry out a serosurvey, which was nested in the post-coverage evaluation survey in Zambia.
Great.
All
Before we go any further, Charlotte, I want to just mark a pause to say hello to some of the folks joining us on across the different platforms. So hello to Jyoti Lande connecting from India, Manoj Kumar from CGPP India. Jyoti is curious about what's new in today's session. Tanushree Mandal says, so many esteemed speakers and so much to know, very, very informative. I would love to leave all other TV series and better watch this one. Emmanuel Musa is joining us from Kaduna, Nigeria. Martha Ngoe, a accompanist and team leader from the COVID-19 Peer Hub, says, great to be here with great minds. Akinyi Marigoretti says, greetings to all from Kenya. Great to be part of the team. Oruj Ashraf says, hi from Pakistan. Kingston Kamkara from India. Anish Shah from Nepal. And MM Okan says, hi from Nigeria. Back to you, Charlotte.
Thank you very much, Reda. So I'm going to be starting with you, Simon. What are some of the biggest challenges? Because I know it could be challenging organizing community-based serosurveys. So what are some of the biggest challenges in conducting a serosurvey?
Thank you, Charlotte, for that question. So today we'll be talking about the challenges of conducting community serosurveys. The challenges in conducting community serosurveys can range across all the phases of the serosurvey, and these phases are the planning phase, the implementation phase, and then finally the analysis and interpretation of the results. In the planning phase, you need to make sure that you're answering the right questions, you're using the right designs to conduct your serosurvey. In doing this, you need qualified expertise with different specialties. This poses a very big challenge, and you need to address that early enough to make sure that you've got the right staff to be able to do your serosurvey. When you've got the right study design, you've got everything in place, then you move to the field implementation. During field implementation, one of the big things that you should look out is to make sure that you are able to enroll the people that you actually wanted to enroll, and that most of the people that you wanted to enroll do not refuse to take part in the serosurvey, because that will bias your results. To be able to do this, you must engage the stakeholders, you must be able to engage the community. And engagement of the community comes with a lot of challenges. Therefore, you must think about it in the planning phase. You must be able to develop a plan. And I wish to say the plans for engaging the stakeholders and the plans for engaging the community must not carry a one-size-fits-all approach. It should be tailored to the community that you are trying to work with. Once you've got that in place, you have to know that to be able to carry out any type of survey, it requires a lot of resources. By resources, I mean financial resources. There are costs involved. Any survey is expensive to conduct. But for serosurvey, there are additional costs that you should be prepared to incur. You know that you have to buy logistics or supplies for doing the lab work. You must buy the kits. You must pay the laboratory staff. But in addition to that, when you're doing a serosurvey, you have to know that you need to have more time in the field as compared to an ordinary survey. Therefore, even the personnel costs go up. So serosurveys are costly. That is one challenge that you're going to encounter. Once you've done all your field work, you've collected your specimens, you've transported them to the lab. One very important thing you should look out for is you should be able to turn out your results in good time, so that you provide the results to the program managers and they can use them for programmatic decisions. Most of the running of specimens for serology takes a bit of time. That is a big challenge. However, with the COVID-19 serosurveys, we've been able to learn that serosurveys can produce results in good time and be used to make programmatic decisions.
Thank you very much, Simon. And now over to you, Kyla. What are some of the most important sources of bias?
Hi, Charlotte. It's great to talk to you. So I think, we always say that community-based surveys generate the most representative results. And in an ideal circumstance, a community-based or household serosurvey will generate the best unbiased estimate of who is protected in your population. But that only is true if you execute the survey and design the survey properly, and as Simon said, have high participation rates. So bias can happen at any stage in a serosurvey. Bias is any systematic error that affects the representativeness of your results. Like Simon said, it usually happens by if you don't enroll the people that you're attempting to enroll, or the people do not want to participate and refuse. So a good example might be excluding migrant populations. So let's just say you need to know the proportion of kids that are susceptible in a district to measles. And because you want to know if you need to do an extra additional vaccination campaign in that setting. It's a rural province. There are many migrant workers in that community who live in temporary housing. So one of the risks of bias there is that migrant workers in your population have lower vaccination rates, and that they might be more likely to be susceptible to measles. So if you do a survey and design it and don't include the settings where that population lives, you have a risk of underestimating susceptibility in the community. So you have a biased estimate. So it's really important in the planning to make sure you think about, are you attempting to enroll everyone that you're trying to analyze and include in your survey? And then one difference between surveys and serosurveys is there's an added layer of bias on the side of lab testing. So it's very important to make sure your lab testing is done well so that you don't systematically overestimate or systematically underestimate the levels of protection in the community.
Thank you, Kyla. Simon, you mentioned the COVID-19 pandemic. How can we implement a serosurvey during the COVID-19 pandemic, and how do you protect both the participants and the staff?
Thank you, Charlotte. That's a very good question. As you may be aware, right now during the COVID pandemic, a number of serosurveys have been conducted. Most of them related to COVID-19. Yes, you can do a serosurvey during the COVID-19 pandemic. Bill and I and Kyla and Andrea have been able to do one. But before you can engage in that, you have to ask yourself questions. What is the urgency of what we are doing? How is it going to help with the pandemic? What are the trade-offs? And when you answer those questions, if you decide to go ahead to do the serosurvey during the pandemic, you have to make sure that you protect, firstly, the participants, as well as the serosurvey staff. You have to make sure that you abide to all the social distancing guidelines. You have to make sure that you provide personal protective equipment for all the participants, as well as the serosurvey staff. For the serosurvey that we recently conducted at IVAC, we conducted it in Zambia during the period of the pandemic. This is a serosurvey which was nested in the 2020 mass vaccination campaign. We had to make sure that we provide all those things I've mentioned. And one of the lessons we learned was that even simple things like transportation of study participants, we have to make sure that we provide for extra cars so that our study staff are safe, they are not congested. We have to make sure that at the study sites, we arrange the study participants in such a way that they are not congested. If a mother was bringing a child to the health facility during that period has no mask, we had to make sure that we provide the mask. So you have to ensure that you consider the safety of the participants as well as the safety of the study staff. Very key in doing a serosurvey during the pandemic.
Okay, and with all of this, what can possibly go wrong?
Yeah, in implementing serosurveys, a lot of things can go wrong. And these things which can go wrong at all different phases of the serosurvey, during the planning phase, during the implementation phase, and during the analysis of the lab specimens, as well as analysis of the lab results. One thing I would want to caution or talk about is to make sure that you respect the person. When you're doing a serosurvey, you have to respect the person. You have to make sure that the information you're collecting is treated confidentially. You have to make sure that the storage of the specimen which that person has given you is done correctly. You have to make sure that the analysis of that specimen is done meticulously, and you must make sure that the people handling the data are looking at the data, reviewing it, and making sure that you are collecting the correct piece of information which will be able to address the research question that you are talking about. If you do that, you'll be able to avoid all the things that can go wrong during specimen collection, and things that can go wrong during the data analysis.
Thank you, Simon. My last question is for you, Kyla. What questions have you been able, you as IVAC, have you been able to answer using Serosurveys?
So this is a good question, and there are many questions that many different groups have been able to answer in using Serosurveys. Today, I will focus on some of the things that we've learned. And at a very high level, we've learned about how to do Serosurveys and how to do them well in an unbiased way to answer the questions that are important for immunization programs. So like we mentioned earlier, we want to make sure we're conveying what we've learned to professionals around the world who are also doing Serosurveys. And much of what we've learned focusing on Serosurveys for vaccine preventable diseases is directly relevant to Serosurveys for SARS-CoV-2, right? How you do it and in the field and back in the laboratory is directly translatable. So a couple, I want to highlight two things that I think have been really important learnings for us with Serosurveys. In Zambia, we did a Serosurvey after a measles and rubella campaign. And what we learned there was that, we confirmed that the prevalence or the protection against measles and rubella was extremely high in children who were eligible for the campaign. It was a great indication and support of that the campaign was effective. But we also enrolled people who are older than the campaign age range. So that's important because post-campaign coverage surveys are focused on kids who got the campaign. And we wanted to say, well, what about the whole population? Who are people above the age of 15 years protected or susceptible to measles and rubella? And what we learned from our Serosurvey was that, in fact, there was a small immunity gap in individuals who are just above the age of the campaign, 16 to 30 years old, particularly among women, to rubella. So suggesting there's an immunity gap to rubella at that age group. And that's important to know because, as many of the professionals in this group listening to the call know, that rubella immunity is very important for women of reproductive age. So that was one thing that was really illuminating for us. Another important thing we've learned is in India, they did the largest measles and rubella vaccination campaign in the world in the past few years. And everyone wants to know, what was the impact of that campaign? Are the children protected because of it? And we were through Serosurveys that we conducted before the campaign and then after the campaign, we were able to directly evaluate the impact of the campaign on protection for measles and rubella. So it was really illuminating and an interesting way to evaluate how to do Serosurveys around the world.
Thank you, Kyla and Simon, for answering my questions. Right now, I'm going to turn over to Reda for comments or questions that could be coming from our various social media platforms. Over to you, Reda.
Great. All right. Thank you, Charlotte. We've got a lot going on and some really good questions, actually, from people who I know were there on the previous days and following along with this mini-series that we're doing, the Geneva Learning Foundation with, and thanks to the International Vaccine Access Center and the experts that are contributing today. So let's start with, let me go back to the first question. Well, actually, I first want to acknowledge, and I'm really happy, Abidemi Olatunde, who's joining us from Facebook, who logged in, who couldn't find us yesterday, and she's now been able to connect. And I hope, Abidemi, that you'll find this interesting and useful. So have a question from Marta Ngoe that actually, I don't know, I hope you can see this. I'm going to read it. So she says, currently in Cameroon, sample collection for serosurvey is going on in all 10 regions for the COVID, which will, let me see, which will end by the 30th of December. The major challenge here is obtaining the consent of caregivers for children under 5 to be enrolled into the study. This may give room for some sort of bias. What can be done to minimize this bias?
I can begin. I think the most important thing is to start by building strong connections with the community, with the key stakeholders in that community, which I'm sure you've been doing. And it's always a sensitive conversation to request blood from a young child who is healthy. So that you have to do the best you can in building those communities. It's true there could be a risk of bias because the younger children will be underestimated. I think it's documenting how many people refuse, what their ages were, so that you know where your missingness is, and then you can better understand, were those missing people who you didn't get data from, were they more likely to be protected exposed to SARS-CoV-2 than the people who were enrolled in your study?
Simon, would you like to complement that?
Yes, the most important thing, like Kyla said, is to make sure that you engage the people. It's always very challenging to enroll children who are young. In most of the serosurveys, there are a lot of suspicions. People talk about satanism, but you cannot overemphasize the idea of engaging the community and getting the information that you need. The other important aspect, which Kyla has also mentioned too, is the fact that we have to make sure that you collect information on the people who are refusing, so that you are able to, when doing your analysis, you consider that information in your analysis.
All right, thank you. The next question is from Manoj Kumar Shodari via YouTube. So Manoj Kumar just wants to know, what are the guidelines to inform the result of a specimen test to individual survey participants?
This is a really challenging and important question to ask. So I can start, and I will not be able to answer all of it. But I think the most important things to consider here are, what is the information you're collecting, and what results will you have? When will you have them, and can you get them back to the person in a timely manner? How important is it, and how will it affect the person's decision-making, safety, and well-being to know that answer? And then how are the tests appropriate for sharing individual results? So for instance, in Zambia, the tests that we use to evaluate protection against measles and rubella are population level tests. They're not designed to diagnose who is susceptible and who is protected at an individual level. So what we do is we share those results back to the district health work, or the district community staff, to the EPI program, but we are not able to share them back to individuals because of the limitations of the test. But this might be different if you were doing, for instance, if you were doing HIV testing. It would be unethical not to share that information. So I think there are a lot of considerations to look into.
And Simon?
So the sharing of results is always a very big concern. So you must understand, when you're doing a serosurvey, the kind of test you're using. Is it for diagnostic purposes, or is it something which you're using to make a community diagnosis? For both cases, if it's something diagnostic where you must intervene, you have to make sure that the results are communicated back. Kyla uses the example of HIV, where you must intervene. If it's for community diagnosis, even then you must be able to explain that, to communicate the results back to that community, but will not be able to share the individual results because they will not be used for any clinical interventions. But it is very important that you share the results with the community, where you've collected that that data, where you carried out the serosurvey one way or the other.
Thanks. So actually, Abidemi Olatunde I remember her message now yesterday, and she had a question, which and it is the following: do people receiving the COVID-19 immunization react to it negatively? So it's natural, given the current context, that there would be questions about COVID-19 vaccines, not strictly speaking within the scope of serosurveys, but because we have three experts, I'd like to turn to Bill and just ask him to give a quick, if it's possible, to give a quick answer to that question.
And Reda, maybe I had a similar question in mind, just to ask, in their experience of organizing serosurveys, have they had communities that were hesitant to vaccination, also hesitant to accepting the serosurveys, and how were they able to handle that?
All right, Bill, would you like to?
Yes, Rita, thank you. I'll take the question around the COVID-19 vaccine. So obviously we know the most around the messenger RNA vaccines, the Pfizer and Moderna vaccines. There are several types of adverse reactions we've seen. By far the most common is what we call reactogenicity, that many of the listeners will be aware of. This includes soreness at the site of injection, some headache, muscle aches, joint pain, fatigue. Some people have fever. This happens within 12 to 36 hours after the vaccination as part of the inflammatory response. We have heard about, first in the UK and then most recently in the United States, some individuals have a more severe allergic reaction, what we call an anaphylactic reaction, that has required treatment. This is very rare. We're still trying to figure out what component of the vaccine is inducing this type of reaction. We don't know that yet. So those are the two kind of types of reactions: the reactogenicity, transient, no long-term consequences. People are a little more concerned about these more severe allergic reactions, but it hasn't necessitated a pause or stopping in the vaccination programs.
Thank you, Bill, for that answer. That's really an aside. Technically speaking, we're outside the scope of today's topic for part 3 of this mini-series, which is really looking at challenges with community-based serosurveys. But Abidemi, because you came back after yesterday, and Bill is probably one of the best people in the world, the most capable people to answer a question like that, we're happy to ask. Now, back to the regular programming, and back to the questions that are piling up in the comments. Thank you so much. I'm afraid we're not going to be able to address everything. Tanushri Mondal alone has 3 questions. Before I get to them, we have a question from Okon, who says, are there legal considerations in sample collection? Let's do Kyla and then Simon.
Well, I think in all research studies, we always use informed consent and ensure that we have proper consent from participants or caretakers. So from a legal perspective, we always follow the highest standards for human subjects research. And I think that is important to ensure you do that, whether you're doing it within the frame of a research project or in the frame of for immunization surveillance.
All right. Simon, is there anything you'd like to add to that?
In terms of specimens, we have to make sure that we abide to the highest ethical standards. Like I mentioned earlier on, you have to respect the person who has committed himself or herself to donating that specimen to your study. So we abide to all the ethical regulations, make sure that we maintain the confidentiality of the person who has donated the specimen. We meet all the standards that are required. If the specimen is required to be destroyed after doing the test that we do, we make sure that we do that. So you have to comply to all the standards that are stipulated in the ethical approval that you get when you're working with specimens.
Great, thank you both. All right, we're obviously way over time here, but obviously there's some really good questions here. Adamu Abubakar from Bauchi, Nigeria says hello to everyone. Now, I'll give you sort of rapid fire Dr. Tanushri Mondal's 3 questions. Question 1, what has been the experience of IVAC in securing consent of people in community serosurveys? 2, what was the objective behind the serosurvey in Zambia during the pandemic? And 3, what are the inclusion and exclusion criteria for such serosurveys, and specifically the one done in Zambia? So we'll turn to you with these 3 rapid-fire questions, and then call it a day for this third episode in this 4-part mini-series. Kyla, and then Simon.
I'll answer question 1 and pass 2 and 3 to Simon. So with consent, we actually had pretty high enrollment and participation rates, and that's in large part because of the engagement of the organizations that already knew those communities that did the data collection, and also the extensive community engagement and stakeholder engagement we did. So generally positive, but very important just to make sure the parent or the participant understands the purpose and understands how their specimens and their data will be used.
Okay. Now, to answer the second and third question, let me give a context first. Zambia is in the process of moving away from doing mass vaccination campaigns every 4 or 5 years to targeted mass vaccination campaigns. And this year we were holding a mass vaccination campaign for measles and rubella. So the research question that we are trying to answer in this mass vaccination campaign, which was conducted during the pandemic, was mass vaccination campaigns capturing children who are susceptible to measles and rubella. The only opportunity we had to answer this question was during this mass vaccination campaign. And we need this piece of information for us to be able to make the decision whether the country should move away from nationwide mass vaccination campaign to targeted mass vaccination campaign. So this was very critical information, and this information can only be collected during this period. Hence the reason for conducting this serosurvey during the pandemic. However, I should be able to say that we had to make sure that we comply to very high standards to ensure that we protect the safety of the participants as well as the serosurvey staff.
All right, thank you. Thank you both. Thank you, Bill Moss from the International Vaccine Access Center. So this was a kind of double episode of our mini-series on the serosurveys with the International Vaccine Access Center. I'd like to conclude by pointing participants to the serosurveytools.org website that has been established by the team at IVAC. Probably currently the best, most comprehensive resource. That's not boasting, that's just a fact. Would you agree with that?
Oh. Yes, thank you, Rita.
All right. So definitely go look at that if you'd like to go beyond what we're able to provide in a few minutes in the live session. For those of you who are looking for reliable information about COVID-19 vaccines, I would also recommend you look at the communication being issued by the International Vaccine Access Center and the Johns Hopkins School of Public Health are certainly a reliable source, as well as, of course, the WHO, the World Health Organization resources to find answers to questions like these. WHO is doing live sessions pretty much every day and reinforcing, strengthening their communication. So if you're an immunization professional, you have sort of general questions about the pandemic, this is not the place to come ask them. We're really specifically focused on serosurveys, but we understand the questions are there. And in fact, we're also doing a number of other events. You can, if you go to our Facebook page, you'll find the page on COVID-19 vaccine introduction. This was with Anne Lindström from the World Health Organization. We just finished this morning, specifically really deep diving on vaccine confidence, demand promotion, vaccine hesitancy. And then we're super pleased that tomorrow will be the fourth part of our mini-series with the great team from IVAC. So that's it for today. I have one last special announcement for those of you who are still online watching this to the end, and that is the announcement about the Teach to Reach conference. Will be announcing this, and you'll be receiving, if you're on our mailing list, you'll be receiving the invitation to register for this conference, bringing together global partners together with immunization staff from all over the world. How do we learn and adapt during the pandemic? The COVID-19 vaccine introduction is basically the ultimate Teach to Reach challenge, and we're hoping to bring together many of the partners and many people from countries around these topics. Thank you for having joined us today. That's it with this almost triple episode. I'm going to do a rewind of all of the questions and comments that came in. There were more questions and more participants today than in the previous episode, so that's a good sign. Thank you and goodbye.